Coming up next on It's Personal, brought to you by Gundersen Health System, it's all about the heart. In this show, we're going to talk about MetaBalance. It's a program helping patients with certain risk factors, many of them heart-related, and teaching them to stay healthy. Also, a little bit later, we're going to talk about a mix procedure for heart patients. Now, mix is making a big difference for patients who actually need heart surgery. We're going to talk with Dr. Rabindra about that and how he's actually taking that procedure and teaching others about it. That's all coming up next on It's Personal, brought to you by Gundersen Health System.
Dear Gundersen, like any child, my son Joey was extremely nervous before ear tube surgery. But Dr. Seek had a surprise for us. He told my son that he would wake up after surgery with a dinosaur tattoo, and we would have to find it. This caring and creative idea turned my son's fear into a smile. Thank you for showing us what love plus medicine really means. Sincerely, Joey's mom, Alicia. P.S. The tattoo was hidden on the bottom of his foot.
Welcome back to It's Personal, brought to you by Gundersen Health System. I'm Christopher. Well, MetaBalance is a journey to really better health. And it seems that if you just make some simple changes, they can actually lower your risk for things like heart disease, stroke, and diabetes. Here to talk a little bit more about that is Michelle Dunlap. She's a clinical exercise physiologist at Gundersen Health System. Thanks for joining us.
Thank you, Chris. Thanks for having me.
Well, let's talk about MetaBalance. What is it? How did this start? And who does it help?
Well, MetaBalance it's an 11-month program it's an evidence-based program where we've worked with patients that have what we call metabolic syndrome. So metabolic syndrome is a cluster of risk factors that does put people at risk for heart disease, stroke, and or diabetes.
So if I have metabolic syndrome, I should know that from my doctor before
Yes.
I get to be a part of this program, MetaBalance?
Yes, it includes several lab tests in that, but 1 out of 5 Americans do have what they call metabolic syndrome.
And what age does that usually start?
It can start at any age.
Okay.
And this program is really open up to any age of patients as well.
All right, so what we're trying to do is get all of us to live longer if we have some of these risk factors. What does the program entail?
Well, first, to qualify, you have to have metabolic syndrome. So let me explain what metabolic syndrome is. It's a cluster of 3 or more risk factors. Okay, the risk factors that they look at is having a fasting blood glucose 100 or higher, resting blood pressure of 130/85 or higher, a triglyceride level of 150 or higher, a body mass index of over 30, or for women, a waist over 35, and for men, over 40 inches.
Okay.
Also, a low HDL. HDL is your good cholesterol. Less than 40 for men, less than 50 for women.
Sounds kind of specific, but you're saying 1 in 5 Americans. That's a large group of people.
Yes, yes.
All right. How are we helping those individuals?
Well, the main goal of the program is going to be a 7% weight loss. And it's also incorporated with adding 150 minutes of moderate aerobic exercise per week. So we're trying to change lifestyles to make this more of a permanent change.
How do you get individuals to make that change? Is it a mindset? Is it a physical thing?
Well, the program, like I said, is 11 months, so it's not a quick fix. It's not a diet program. We do meet once a week. Our next program, we meet on Wednesdays. So the first hour is actually with a registered dietitian and also a clinical exercise physiologist. We are certified wellness coaches as well. So it's changing those habits, it's learning about healthy eating, healthy exercise, and behavior modification.
All right, for a lot of individuals in this, though, I got to think this has been a lifelong thing.
Yes.
You're talking about eating. We've all been eating all of our lives. How do you get somebody, to change their mindset? What does MetaBalance do to when you meet with an individual as a exercise physiologist?
Yeah, well, we're not telling people what they can or can't eat. We are guiding them to do more of what we call intuitive eating. It's listen to our bodies, what naturally we were intended to do. To eat when we're hungry, eat for fuel, okay? And also to be active, adding more activities and also regular exercise. So the second half of the program, first hour we meet is more of a lecture. The second half we meet at the new Healthy Living Center at the YMCA in La Crosse.
Okay.
Very nice facility. So we're also exercising these people. That's where we do a lot of our coaching as well.
All right.
We're guiding them in their program.
I think coaching is kind of a big word.
Yeah.
And is that what this is about, a lot of it for these individuals, coaching?
It is. Most people know what they need to do. So it's how do we help them to actually do it, to develop new habits, to learn to enjoy that. It's in a group setting. It's a smaller group, so they learn from each other as well.
All right, we're talking with Michelle Dunlap. She's clinical exercise physiologist at Gundersen Health System, and we're talking about MetaBalance. And I know one of the questions that I should ask is, has MetaBalance been successful?
Yes, actually some of the outcomes that we've gotten from our program that's been going on over 10 years is that we do see at least a 7% weight loss in our participants at the end of the year. There's an average 10-year coronary artery disease risk that we look at, and that has decreased by 23%.
Unbelievable.
Yeah, and then there's a 75-point-year diabetes risk that we look at. That's also decreased by 25%. So making changes in these lab values, we've seen decreases in their cholesterol levels and also increases in their good cholesterol levels. So we've seen the difference it makes when they're following this healthy lifestyle.
What do patients say is that difference maker? What's the feedback you're getting from those individuals that are part of the MetaBalance program? Part
of it is the accountability, knowing that, hey, I want to get better, and we do goal setting weekly, monthly. So it's just checking in with them and getting the support they need to continue it. We want to make sure they're ready for that commitment. This is a program that's typically covered by insurances, and
okay.
it is specific insurances. We also do offer some out-of-pocket costs, but options. But we do make sure they are at that point where they are ready to change and want to make that commitment.
All right. Now, I know you mentioned that sometimes insurance covers this. How do I find that out?
Well, one of the best things to do probably is to call our number. I have a number that I can give out. We also have an information meeting coming up. It's on May 3rd, 5:30 at the La Crosse Healthy Living Center, YMCA.
All right, May 3rd, what time on May 3rd?
At 5:30.
All right, I know one of the phone numbers we have is for one of your staff members, exercise physiologist, and that's 608-775-5361, and we'll provide that number again, but it's 608-775-5361. Talk about the fee in case my insurance doesn't cover it. What is the fee for the 11-month program?
Well, the fee, actually, if it is covered by insurance, we are asking a $250 commitment fee, which is actually returned if you meet the criteria. Okay, so for a lot of people, it's a free program.
Okay.
Out of pocket, that's something we can also address with you if you call our number to see if you qualify or not.
All right. How do you continue with the support through the program? Because you're not going to be there 24/7, and some of us worry about slipping back. How do you provide that support?
That's a great question. The first 12 weeks we do meet once a week. Our staff, we are available through email or phone calls if needed, but we also are encouraging people to get their own support, their families on board, their coworkers, because it's not something you can do alone. Mm-hmm. Right? The temptation's always going to be there, but if you can have your own personal support as well, and the group supports each other. We also do a support group, MetaBalance support group that meets monthly. So those are options as well for people, especially once they've completed the program.
All right, very interesting. MetaBalance, and the whole goal here is, I guess you could say, some prevention, because you're talking about preventing things like heart disease, stroke, and diabetes because they already have many risk factors, and 1 in 5 Americans. That's pretty amazing. So MetaBalance, how do I get information again?
You can call the number provided,
all right,
that Chris mentioned.
Yep.
Or if you're interested, May 3rd, 5:30 at the La Crosse YMCA Healthy Living Center.
All right, or that number, as we mentioned, is 608-775-5361. Michelle, thanks for joining us, and good luck with the MetaBalance program. I hear it's been successful so far.
It has been, yes.
All right. Again, MetaBalance, 608-775-5361. And that's Michelle Dunlap. She's a clinical exercise physiologist at Gundersen Health System. When we come back to It's Personal, the mix procedure is making a big difference for patients who might need heart surgery. We're going to talk with Dr. Rabindra about that. All coming up next, and It's Personal, brought to you by Gundersen Health System.
Dear Gundersen, my mom told me to write a thank you note for the cool bicycle helmet you gave me for free. It's the same color as my bike, which is mostly blue and some green. I like to wear it so if I crash, like my friend Charlie, I won't get stitches in my head. Charlie said stitches hurt a lot. You're nice. From your friend, Jeremy.
Welcome back to It's Personal, brought to you by Gundersen Health System. I'm Chris Stauffer. Well, mix surgery, as it's called, is very popular. In fact, in talking with Dr. Rabindra just moments ago, he said they're up to about 400 cases, and I'm going to let him dive into that and talk more about how this is helping people with bad hearts all over the world now. Joining us is Dr. Prem Rabindranauth. He's a doctor here at Gundersen. He's a heart surgeon and has been doing mix surgery. But before we get too much further, what is mix surgery?
So, Chris, mixed surgery, MICS, M-I-C-S, stands for minimally invasive cardiac surgery. So we've taken bypass surgery, which we usually refer to CABG, or coronary artery bypass grafting, and we now call it mixed CABG, or mixed CABG. But to shorten it, we call it minimal invasive coronary surgery.
And for those people at home, the key here is about what you're about to say, and that is, you don't crack open the chest.
Correct. So the big difference here is the incision or the approach. It's not anything new. We've not invented a new procedure. We are just doing it a slightly different method. And I usually will tell patients, look, beyond the incision, beyond that big cut down the front or the little cut in the side, the rest of the operation is the exact same thing. And people are intrigued by that sometimes. Well, how could you do this through the little window cut? Well, we can because the instruments have been modified, and we've learned how to do it, and we've persisted. The team has gotten better. They see it day in, day out. And like anything else, I always say to patients, if you do it the same way every time, guess what? It gets easier. And so that's where we're at now after 7 years of doing this. It's like second nature to the team. 7
years and about 400 patients that you've opened up a little window in their rib cage. Correct. Versus cracking their chest open.
Yes.
And I'm sure you've had now maybe a patient or two that have had both?
Yes. So, well, I don't know if you're alluding to whether during the case, if we can't get it done. Some patients have asked, well, when we talk about it before surgery, if you can't get it done through that little cut, the 3-inch cut between the ribs, can you still open the chest? And we'll say yes and no. Yes, we can, but no, we don't have to, because there's another bailout method. And that is, we make a small cut about 1.5 inches or so in the groin area, and we hook up to the heart-lung machine using the femoral artery and vein. That's the blood vessels that go into the leg. And so then we will start up the heart-lung machine. We still don't stop the heart. So the pump is taking over circulation. It decompresses the heart by taking all that volume of blood out of the heart, and it gives us a little bit more space and leeway to manipulate the heart inside the chest. So the patient is stable, the heart's still beating, and we have more room to work.
The big deal here is recovery time too. If you crack open the chest in a standard heart operation, the recovery is usually getting the sternum to heal. Is that correct?
Correct, absolutely. The sternotomy, that big cut down the middle or cracking of the chest that we talk about, that's splitting the sternum or the breastbone down the middle. And then we rewire it to get it to heal. We can't put a cast there like you have a broken limb. You put a cast for 6 weeks. It takes 6 weeks for bone to heal. Those wires will stay in there. And patients will frequently have discomfort long after the 6 weeks. So generally we'll tell patients you need to be off of work or no heavy lifting for at least 2 months, to give you a rough idea.
So if I'm someone who needs heart surgery, why would I ever have my chest cracked open? And I know not everyone qualifies, but is it just sort of an information gap here that many are not aware that there is another way?
There is a little bit of that. I think, well, mostly from a patient standpoint, there is that, but also a lot of physicians don't know about it. But secondly, Chris, the problem is there's not enough data for some of the newer stuff, as you can imagine. But then again, if you think about it, how do you get to new procedures? You have to start somewhere. And the data has to support data, the new procedure outcomes have to support the data that's out there already. And that's been the case with this operation. There was one big paper that came out in 2009 from Dr. Joe McGinn, who, basically innovated this operation and published in 450 cases at the time. And the results were remarkable. They were within all the expected, data pieces that we look at: mortality rates, stroke rates, bleeding rates, etc. Everything was within that benchmark that we look at from the Society of Thoracic Surgeons data.
Wow, absolutely amazing. We're talking with Dr. Prem Rabindranauth. He's a physician here at Gundersen Health System and is also a heart surgeon about mixed surgery, a minimally invasive procedure that really takes care of the heart. And this procedure, you've said now we've been doing it, I want to call it a new procedure, but it's not anymore. Like, as you said, it's been around for a while and you've done over 400 procedures. And from what I understand, people are coming in now to learn how to do this from you.
Yeah, not only that, but alluding to something you talked about earlier, patients not knowing and such.
Oh, yeah.
We have patients coming in from outside of our area, outside of town. We've had patients from as far away as Alaska. We even had one recently from the country of Colombia. Patients from the eastern part of the state, because patients are finding out about this stuff nowadays. You could read about it online, and as I said before, sometimes physicians aren't fully informed about it. But the point is, if the data is out there, the outcomes are good, it's a safe procedure. Whenever we can offer it, we will, because from a common sense standpoint, as you suggested.
So how do I get data? I'm listening to this show and I'm thinking, my doctor talked to me about needing heart surgery in the future.
Yeah.
Where do I go?
So nowadays, most people will glean all this stuff from the internet, right? Send an email or make a phone call. And then generally our office staff will field these calls. They'll get back to patients. They'll have them send in some preliminary test results. And then they'll decide based on that, and by talking with me, we'll decide if the patient seems a reasonable candidate before they make a trip all the way to town. Because sometimes they may not even qualify for surgery at all, or for whatever reason may not be a candidate. But generally patients will come in and we'll evaluate them, and if they decide they want to stay and have surgery here, then we'll make arrangements to have
I think it's kind of one of the things that you and I've talked about is it's kind of ironic that sometimes patients will ask their provider in another health system, and the provider might not have heard of the procedure. So don't necessarily just stop there. Maybe ask further, take that extra step to go on the web, to make a phone call to Gundersen and say, hey, can I learn more?
Absolutely. It's not uncommon that we've heard that story from somebody that's come from far away. The problem is most times when patients have coronary disease, if you think about it, they went into the hospital with some kind of chest pain or maybe a heart attack. In those cases, it's kind of difficult to get out of the system because you have your EKG test and your enzymes test and your stress test or whatever, and something is positive, then you end up in the angiogram table. They're being told right there, families being told, patients being told, you need to have something done, whether it's a stent or bypass surgery. And generally, it's being done, for most cases, at the same admission. So it's hard to get out of the hospital because all of a sudden, most patients who don't know anything about this, may think, well, this is very serious. I got to stay and have this done. But truth of the matter is sometimes, not all times that you need to stay. Not all times it's an emergency. If you had a heart attack or something serious, that's different. But in some cases, they're more of what we call an elective basis. You can go home for a few days and all that. So those are the patients that will end up researching and calling and coming from far away. So it's difficult when you're in the hospital. I agree.
Yeah, no kidding. And then, having family members too being your advocate as
Correct.
well is a key part. And sometimes I know it's not the person who is the patient, it's a spouse
Yes.
that makes that phone call. I wanted to get back to the fact that we have, you've brought in several people to learn the procedure from you, and that's because they see the benefits.
Absolutely. So that speaks, I think, volumes for the actual procedure, the method, because if surgeons are coming in from around the country and around the world actually to learn this, then, and they want to incorporate this in their practice, it's a good thing right there. But again, patients wouldn't necessarily know all of that on the outside, and sometimes some family practice or internist physicians don't know any of that either, which is partly why we have to put some of these little stories out there. So recently, as you know, we had 6 Brazilian surgeons come in. This was actually the 4th group of Brazilian surgeons. Groups of 5 surgeons have come in the past. We've had surgeons from Colombia and South America. We've had Chinese and Japanese surgeons as well, and then a host of surgeons from across the U.S. Some have brought their teams, because I think that's also important. If surgeons are serious about getting started in this, it's nice for the team members to know, how it all gels together and what role do they have in the whole process, and makes it much easier to go back and implement the stuff in your practice.
So what's the feedback that these heart surgeons are giving you from China and Brazil and elsewhere?
We've always wondered how many of these surgeons who have come here have gone back and implemented this in their practice. And, the results might shock you, but, you would think, well, gosh, everybody who's here seems so enthusiastic and so ready to get back to it. It would be closer to 100%. It's a little bit hard to collect the data, but what we're being told, it's probably somewhere less than 20%.
Okay.
And part of the reason for that is, it's not as easy as we might make it sound. And we're, sure to point that out when surgeons are here watching this stuff. We try to show them some of the potential pitfalls and some of the little tricks that we have to make some of the stuff easier. But, let's face it, it is a different approach to doing the thing. They're used to doing surgery, but it's a different approach. And like everything else, you kind of have to get used to it. So surgeons will go back, they might do a case or two, they might find it a little difficult, and they might abandon the thing.
And some of that might be time for the surgeon, because learning anything new takes additional
Correct.
time, and I know that you've said that this is harder on the physician,
Correct,
but much easier on the patient.
Absolutely, and that's what the important factor there is to remember, that it's better for the patient, it's easier on the patient, it's easier recovery. And don't forget, we've shown in our own data as well, we've published our own data, that the results are well accepted, the bad outcomes are very low, and it's well within the range of what's accepted as far as the national data goes. And so if we can persist, take that extra effort and make this thing work, it's all about what's better for the patients.
Yeah, I know some heart surgeons are out there more worried about their volumes and those kind of things, but kudos to you for saying this is better for the patient. And the recovery time is just so much shorter. I know you've been trying to track that, and sometimes you have to reel those patients back in. Hey, it's not time to go out there for that jog yet.
Right.
Because you feel good, you still have to wait a little bit. Can you talk about the recovery time for the patients themselves?
So the basic premise there is the fact that we're not cutting the bone. With the sternotomy, the big cut in the front, with that approach, with the wires and all that, the healing time, 6 weeks to 2 months or so. With the little cut in the side, because we're not cutting any bone or affecting the ribs at all, we're just spreading a little bit in between, it's all just soft tissue, muscle, fat, and skin that has to heal. And that usually heals, within a few weeks. So we tell patients, take it easy for at least a month. Same as if you have a hernia operation or any other small operation, surgeons will tell patients, take it easy for at least a month. Let things heal. So we've had patients within a couple of weeks are really feeling okay and ready to go, especially the younger patients. So it's very hard to measure that though, because not everyone goes back to work. Our retired folks don't work, so we can't measure it by saying earlier return to work. Earlier return to normal activities. What's normal activities for everybody?
Right, and a construction worker versus an office worker,
correct.
too, going back to work
Absolutely.
is also a challenge.
So we have anecdotal data, we have cases, we have the teacher who's gone back in 2 weeks, we had a dentist who, on his way back home from the hospital, stopped at the office and saw a few patients because they were there. So little stories like those things that, remind you, yes, this does work for a lot of patients.
Yeah.
We're not saying it's a magical operation, we're not saying you're going to wave a wand and you'll have this thing and won't feel anything, no pain, and you're going to go right back to normal. That's the last thing we want patients to think. All we're saying is that this makes it a little easier. It's still heart surgery, but it makes it a little easier in the recovery. You get back to speed a little sooner.
We're talking with Dr. Prem Rabindranauth, heart surgeon at Gundersen Health System, and about the MIX procedure. Before I let you go, I do want to bring up the hybrid that you've added now to your repertoire. Can you talk about what the hybrid procedure is and how that's making a difference for patients as well?
Yeah, so the hybrid, can refer to different things. The one thing I alluded to earlier was the hybrid in the sense of revascularization, where we would do the one bypass or two, and we would leave the more difficult blood vessel in the back of the heart. The cardiologist will put a stent in that. Or on the flip side, if a patient comes in with a heart attack and it was found that it was an artery in the back of the heart or wherever that caused the heart attack, they come acutely to the cath lab and they will have the angiogram and have a stent put in to fix that. But if they have residual disease, then the cardiologist may send them to us to have bypass surgery, so then we'll do the minimal invasive bypass surgery that way. The other hybrid you might be thinking of also is that we've done some simultaneous heart operations with bilateral mini thoracotomy, we call it, or small cuts, instead of cutting the chest open. For example, if a patient needs a mitral valve operation, but they also have coronary disease and need a bypass done as well, generally, most times we'll say, we have to go through the front, and it's easier to do everything through the front. But if you think about it, we've done mitral valve operations. We do it routinely, probably for about 14 years now here, through the right side of the chest with a small cut. And we've done now 7 years of minimal invasive bypass surgery from the other side. So why couldn't we combine the both of those and do something less invasive for the patient? So not everyone would qualify for this, so it's very highly selective patients, certain patients. But with that said, we actually have a patient in the hospital now that we did a few days ago that way. He's doing remarkably well. Yeah. Because these incisions are very small, the pain associated is not generally what we as surgeons know to be for thoracotomy patients. Thoracotomy are the big cuts between the ribs that we used to make to take lungs out of the chest for cancer. And so those incisions used to be associated with a lot of pain. And so that's the general consensus among physicians, especially some of the older ones who have trained, a little bit ago, that have seen some of those operations. Some of those thoracotomies used to involve taking a rib out even. You cut it out. You don't put it back in. You cut a piece of rib out just so we have more room to get in there to take the lung out.
Before we go, we talked about recovery time being a benefit. What other benefits are there to the MIX procedure?
So there's some other things that generally people wouldn't clue into necessarily as patients there. But, when we study our outcomes data, these are standard things that we look at. For example, risk of mortality, risk of bleeding after surgery, risk of going back to the operating room after surgery, recovery time as far as discharge from the hospital, blood transfusion and all that. So in our outcomes data that we've published, we found that patients on average are being discharged at least a day sooner. And most of these patients are actually off the ventilator machine in the operating room, up to 70%. And of those ones, we found that it's even a whole day sooner, compared to the rest of the patients that are being discharged from the hospital.
And nobody wants to stay in the hospital any longer than they have to.
Absolutely, and not only that, but the longer you're in the hospital, the more resources you chew up as well from a finance standpoint. So we always encourage patients, if you have the questions, call us, call our office. Our folks in the office are extremely well versed in all of this because they've been doing it for several years now.
And I'll give you the general Gundersen Health System telephone number right now. It's 608-782-7300. You can also check it out on the Gundersen Health System website. But again, the phone number is 608-782-7300, or you can go to gundersenhealth.org. Dr. Rabindra, thanks for joining us and teaching us about MIX. I know you've been teaching it a lot, here recently to a lot of doctors coming in from out of town. So congratulations.
Thank you, Chris. Thanks for having me.
All right. If you'd like to learn more, again, go to the Gundersen Health System website. That's gundersenhealth.org. That's going to wrap it up for this edition of It's Personal, brought to you by Gundersen Health System. I'm Chris Stauffer. Thanks for joining us.